Welcome to the Between Two Ellen shows. It's a good one, and it's a difficult one. We're going to talk about HR1 and the hospitals in our state. Scott Tohlen is on today, and what he talks about is like people don't know about provider taxes. He's going to also talk about rural hospitals and how it affects us. He's going to talk about SHOP. What else
Mhm.
did you
And
take away
let's
from it?
let's let's say what SHOP is because we never say what it is. It's Supplemental Hospital Offset Payment Program.
Us and our acronyms, we
Us and our
forget.
acronyms. But
Yes.
Oklahoma Hospital Association is a statewide association. It's nonpartisan. They're a big presence at the Capitol, and have the pulse of hospitals, both rural, urban, and suburban. And I think he brings that conversation perspective to the conversation today.
And at the end, he tells about how maybe he had a part in this podcast.
That's true. Well, enjoy.
Here we go.
Hello, I'm Ellyn Pogemiller.
I'm Ellyn Hefner, and this is Between Two Ellens. Today, we get to talk about something that is on a lot of people's mind, and there's a lot of misunderstanding, or maybe we should just say we don't know enough about it. And we have someone who's great. He helps us, kind of talks to us about things up at the Capitol. So we've known you, I've known you for a little bit. You can tell us what your job title is, but today I'd like to welcome Scott Tohlen.
Thank you. It's happy to be between two Ellens,
Oh.
as seems to be the case. So I'm Scott Tohlen. I'm the Vice President of Advocacy at the Oklahoma Hospital Association. We are a nonpartisan organization that represents 123 hospitals of the 155 of the state. Of the state's hospitals, 95% of those rely or sit in rural areas of the state. Obviously, we represent the metros, the urbans, the suburbans, everything in between. So from the Panhandle, the Southeast, to Northeast, to Southwest, all members of OHA. Really, the only ones that we don't represent are those who are truly physician-owned. We do not represent ambulatory surgical centers, so truly those hospitals. Oklahoma is unique in that fact, in so far as we are nonprofits, namely 99% nonprofit hospitals in the state of Oklahoma. Many of those hospitals are public trusts, so about a third of those hospitals are either owned by the city or the county. So more than likely, those tend to be supported by some level of local tax base.
Great. Well, thank you. We today, though, because of all of your experience, especially with the hospitals and what's happening right now, you're going to talk about HR1 and how it relates to hospitals between two Ellens.
Yeah. So HR1, known as the One Big Beautiful Bill Act, made some pretty significant changes to hospitals and how they are reimbursed across the U.S., but in Oklahoma, in particular, there are two pieces of HR1 that are having that will have a significant impact upon our hospitals. First, they made a change to what federally is referred to as a provider tax. In Oklahoma, we refer to that as a fee. So nationally, that provider tax is set at 6%. It is being ratcheted down half a percentage point until it reaches 3.5%. In the state of Oklahoma, what that will mean is that ours is set statutorily at 4% today. We will not see that actualization of that drop to 3.5% until 2032. So there is a roadmap of a runway, as we've often heard it referred to as, with that. So we won't realize that until later. There is a cost to that for the state from that difference of that half percentage point, and what that looks like. I think we're all having conversations about. I certainly believe that there will be, and the healthcare authority stated most recently this week, that there will be a excess in our fee that's collected by the end of that rundown. And so what we would love to see, and what obviously we will advocate for, is that that fee continues to truly fund hospitals and not go towards other items. But we have had a long-standing partnership with the healthcare authority. This SHOP fee that we talk about really flows into everything else we'll discuss on HR1. So the other key component of HR1, in 2024, the state moved towards a Medicaid managed care system. With the enactment of the Medicaid managed care system came a new reimbursement model for hospitals, referred to as directed payment program.
Mhm.
So when you all at 23rd and Lincoln hear about Sooner Care, Medicaid, or Sooner Select, when you talk about Sooner Care, and I know this is close to you, Sooner Care is those folks that are in the ABD population, the age blind disabled population. Sooner Select is those that fall into expansion category, pregnant women and children, those that are foster care, adoptees, those populations, and then there's children's specialty on top of that. So HR1 made a change to the directed payment program, which currently, well, not currently because we are in current directed payment model. Prior to the directed payment model, Oklahoma hospitals using our shop fee went from senior care rates to 100% of Medicare. That's why the state in 2011 partnered with OHA to put a fee on our hospitals, certain segment of our hospitals. That's all delineated in statute. Put that fee on to get us up to 100% of Medicare. When we had conversations around what Medicaid managed care could look like in the states, obviously a big portion of that was how could we otherwise draw down more federal funds to provide more services or maintain services for Oklahoma's hospitals. In doing so, we got to 90% of average commercial rate. So for the state of Oklahoma, that's a significant increase. When we went live with Medicaid managed care in the state of Oklahoma, that took many rural hospitals from the red to the black overnight. So it was significant for them. For our critical access hospitals, they're almost our smallest of the small when it comes to rural hospitals. Those are reimbursed at cost, and so they are not losing dollars for the services that they are otherwise providing. Well, HR1 takes that directed payment model that we currently have and drops it down 10% beginning in 2028 until it reaches 100% of the Medicare level. That does not cover the cost of care. We're all aware of that. That will be significant over a 10-year phase down. That equates to $6.7 billion for our state's hospitals.
Goodness. I mean, I'm just going to stop just because the amount of information, like I've heard this, we've talked. I know that, excuse me, we hear from federal delegation and stuff too about this, which doesn't sound as similar as what you're talking. My question is that is not any relatable to anyone that is living a life that things are going to really change. And we say 2032, but we're actually seeing some changes now. What is something can you give us a scenario or something about what you just said, especially in our rural hospital, when we start to make these changes? What's something that someone goes to the hospital and may see a big change, whether it's there or not? That could be one.
Yeah, whether it's there or not, I think it's a key. I mean, rural hospitals, in any hospital, you cannot make up for that type of reduction without cutting services.
Right.
Just plain and simple.
And what services would those look like?
Well, we already know that rural Oklahoma suffers from a lack of OB services.
Yeah.
I would expect, potentially some of those that currently exist, perhaps they don't tomorrow. And at the end of the day, obviously, Oklahoma hospitals care for patients. That's what our caregiver teams do. But we are still businesses. We still have to have a margin that is in the black. And so, if you walk into our hospital, we are going to take care of you. So regardless of whether or not you have a payer source, we are going to take care of you. There are other things in our HR1 that we know will have some impact. And not certainly that the association has a position on those, but so much as we know that directed payment is going to have an impact. That is a math problem. That is simple for us to calculate. Whether or not people lose coverage underneath different scenarios that have played out under HR1, those just add to that loss for hospitals.
Do we know, are they predicting how many people will lose coverage and how soon? I mean,
there are certainly those groups out there that are putting out estimates, upwards of 136,000, I think is one that I've seen. But again, the damage is done with the directed payment program loss, and then how much more of an impact we will see whenever folks do not have coverage and they end up in ER, and that is their first point of contact. because of their loss of coverage.
which costs our state more money.
Yeah.
Definitely.
I mean, I think another tangible piece, whether or
People
not,
don't relate that, though.
yeah,
The people don't put those together. Like I said, what you said in the beginning with all that great information, people I don't think, I mean, that can really put that in their practical life. And then know the idea that, how things that we make decisions on federally that affect our state will affect our budget, which in turn means cuts,
mhm.
services, or hospitals closing. Do you foresee any of that since we keep saying 2032? But if you are a business as a hospital, you guys are already deciding what kind of decisions you're making ahead of time to keep you in the black or keep things open or, you're strategically finding care across the state if you're possible. So can you talk a little bit about that?
Well, uh, briefly, you all have been talking about the department, the mental health, and struggles
Mhm.
there. They're facing a $40 million shortfall. I think we're all aware of it. I think 23rd and Lincoln, you know, throughout that building, people are concerned. That is a nonpartisan issue on mental health care and behavioral health care. With HR1, and I hate to speak of it this way, but the providing of those types of services are a financial loser. Like
Mhm.
they do not pay for themselves. And so when you are a hospital and you're looking at areas in which you could trim in order to provide services elsewhere, behavioral health care is probably more than likely going to be those
Mm.
ones because of its loss on margin. And so if I could reuse that room for providing a procedure that otherwise pays for itself, I think you will end up seeing potentially some of those, which just exasperates the issue over here.
Of course. And it costs us more money later on too. I mean, but you're, like I said, you're looking out for the hospitals, so you have to make those decisions. And that's one that is, unless we get our agency, whether they're 40 million in the hole or who knows, 60 million in the hole, we have to figure out a better way to support that. I mean, there's so many agencies or departments or things that aren't supporting each other
Mhm.
that this exacerbates it.
Yeah.
Would you agree?
Yeah.
Yeah, it's starting to, kind of landslide a bit. And I know that people keep pushing it down like they were talking about kicking the can. I was like, I don't know if you're struggling with services anyway, but we're not kicking the can. It's happening now. It's just going to continually getting worse.
Well, and you said 2032, but I went to a presentation at a hospital where they were showing like a 10-year plan and it was year 3. It
Mhm.
was 3 years from now where they were seeing red.
Mhm.
And they presented it to a group of board members and it was silence afterwards. And so I struggled with like what are the appropriate questions that we should be asking if
Yeah.
you're a hospital? What are the type of questions you think they're talking about internally as they move forward?
Well, I think, and there's nothing that I haven't said publicly that I wouldn't otherwise say here. Oftentimes if a rural hospital is struggling, um, it is not unlikely that folks would seek to partner with a larger system
Mhm.
to manage them, and whether that's a larger system, like some of the metro here in Oklahoma City or in Tulsa, or one of our regional hospitals that may manage a number of rural. Um, I would suspect that they're going to have to reevaluate those relationships, right? Because that is still a financial burden for them. But these are we say this all the time at OHA. It is about Oklahomans taking care of Oklahomans.
Mhm.
And so none of this comes without pain,
Mm.
but it is the reality of you have limited dollars, limited reimbursement, and something we haven't particularly touched on yet. But it's all about payer mix,
Mhm.
right? And so
Mhm.
for the state of Oklahoma, the majority of the payers for our hospitals, Medicare, Medicaid, and then third party.
Mhm.
And Medicaid and Medicare make up the majority. And we are the largest provider within the healthcare authority, the state's Medicaid agency. And so when these changes come, they have significant impact upon us.
One of the another things we kind of touched on was like just hospitals in rural areas and workforces. But, we talk about workforce shortage in healthcare communities. But if you don't know that that hospital is going to be there in a year or two, it's going to be very hard for you to recruit physicians, And so trying to create stability in our rural communities. But how impactful is a hospital in a rural community?
Well, we often talk about education and public schools being some of the top employers in rural communities. Hospitals are no different than that. We tend to be in the top two. And we pay far above the minimum wage in the majority of areas. And so, we are top employers in those areas, and especially those rural areas of the state, whether you're talking about the Panhandle or Southeast Oklahoma, et cetera. Um, to your point about workforce, I think what's even, more recruitment is one thing,
Mhm.
but what you often see in rural Oklahoma and many places around the state is they may have a partnership with their local career tech.
Mhm.
And so they are training, on the job within their facilities and vice versa. And so, I would be shocked if you didn't see some impact into those areas in the relationship. So obviously, we need those physicians in rural areas, but we also need other healthcare providers in those areas. And so all of it gets impacted potentially when you don't have the dollars to otherwise go out and recruit and hire and retain.
Was talking to Chairwoman Rose the other day, and she's a provider. She's a provider, and she was talking about how the lack of providers just on their clinic is just it's just intense. She's trying to catch up plus do her job, and she does a great job at the Capitol. My question too, though, is a little bit related to that about, we keep talking about the math problem, but the effects that these decisions that we're making with workforce, with our small towns, rural, even in our urban, do you just think this is one of those dominoes that's if something's not shored up, it'll it'll just happen quicker and affect other areas? I mean, education, your career tech, is that something that you think it's either working all together or this is a real big one that could knock a bunch of them down?
Hospitals are an economic driver across the state, whether rural or urban. And so I can sit here and tell you the math equation of $6.7 billion in loss that doesn't get into how it otherwise spirals out into the rest of the
What I
economy.
like to talk about. I just think the needs of what that's going to happen is always people aren't really paying attention, especially with they if they don't understand your great, the beginning of how you talked about HR1. I just don't think people I think don't understand and who to believe on that too. But continue. I'm sorry.
Well, OHA has had and continues to have outreach with our congressional delegation. And that's important, right? In any conversation, to have those doors open, to have that communication. And they've all been consistent, right? That the state should pick up a greater share of the cost of all of this,
Mm.
and always open to having those debates and conversations. I think, for Oklahoma, recognizing that we are potentially more negatively impacted than many other states. And so just being cognizant of that. And I think, to some degree that they certainly are. And I haven't talked to anyone at 23rd and Lincoln that isn't concerned.
Mm.
And it is certainly fostering a greater conversation about what does healthcare look like and what does healthcare look like in rural Oklahoma long term. Um, and I think folks recognize that this is potentially going to be very painful.
One of the aspects of HR1 was also a 50 million rural. Was it?
RHTP.
RHCP,
Okay.
Rural Health
The
Transformation
transformation.
Program.
I
Okay.
was just gonna ask.
Can you tell us a little bit about that program? We talked about it a little at the Capitol this week.
Yes. Yeah. No, great question. Because the Rural Health Transformation Program is often referred to and has been referred to as a fund for rural hospitals. That is not what
That's not
HR1
what it
says.
is.
HR1 says that it is for certain hospitals, certainly rural, but also for federally qualified health centers, for certified community behavioral health centers, CCBHCs. Those entities are also able to apply for those dollars. But more importantly, the $50 billion fund nationally, that doesn't, it can't be used for operations.
No.
Mhm.
And so it doesn't even if it were to be able to go towards hospitals operations, it wouldn't even make up for a third of what we were otherwise losing underneath the directed payment.
Yeah.
And that was the piece I didn't know until this week that someone asked, are those one-time payments or is it ongoing? And they described it as one-time payments, and I thought, well, that's not what that was not my understanding when I originally heard about it.
There's more guardrails on it than what was initially came out.
It is a 5-year program. So it's a
Mhm.
5-year grant program. I think the state could, at a minimum, expect to see $200 million per year at a minimum. I think it has been said numerous times that Oklahoma would otherwise qualify for meets the metrics for many of those items underneath the grant program. And so certainly looking forward to any conversations that the delegation has to ensure that those dollars really do come back to the state of Oklahoma. And we at OHA, we have submitted our own requests for information to the Department of Health for ideas for how to otherwise utilize those dollars.
Department of Health is the one that's managing that for
Yeah.
us in the
Okay.
state.
Okay.
Yeah.
And they're working really hard on it. I got to go with Representative Stinson to go and talk about that when we went to DC, and they're helping give us some ideas on how to do it with the Department of Health, and I think they're really trying to understand, because there is a clawback in it, that to do it in the right way, so we end up getting all of the money that we can, even though it's not enough for what you were talking about. So I do think that behind the scenes people are really trying to work together. I've seen more, I don't know, agencies and people coming together than I have. Mostly we silo ourselves, but I was really, if anything, that's some good news that maybe come out of this, is that we're really trying to work Oklahoma together.
Yeah, I absolutely agree.
Yeah.
We've had open dialogue with Commissioner Reed at the health department and others. And we don't see that door shutting, anytime soon. I think the team that they have there at the health department that is really spearheading all of this, they're doing their due diligence. They view this as, I believe, certainly President wants it viewed as, this is a opportunity to have a real transformational impact. And so with the team that Oklahoma has in place, I'm, want to be hopeful about that. And so I think time will tell.
And bipartisan, I will throw in that too, not just the agencies and working together, but it's nice when, someone asks, someone on the other side of the aisle, hey, can you sit in on this? And so I appreciate that too. Or then even ask a question. But what questions what's like the wildest misunderstanding do you think is out there about HR 1 in Oklahoma?
The wildest misunderstanding.
That's being out there, like you said, when in the conversations that you have, because I think sometimes what you're saying, or what we talk about 23rd and Lincoln, and how there's an understanding about working together and stuff, but sometimes I hear what's out there that doesn't really match what I'm reading or you're doing or saying or promoting for or talking about for Oklahomans.
To some degree, I think it has to do less about HR 1, and it has more to do with the lack of understanding of how our shop fee really undergirds the
Okay.
Medicaid agency.
Okay.
And so when I talk about our shop fee, that went into place in 2011. That is a tax voluntary fee that hospitals placed on themselves, a certain segment of hospitals placed on themselves, to give to the state. It is the state's match to draw down more federal dollars. As I mentioned earlier, that got us up to 100% of the Medicare level. That, whenever State Question 802 passed on Medicaid expansion, our fee was set at 4% to help pay for Medicaid expansion. So not only does it pay for that state share, generally for drawdown, whenever expansion occurred, then it paid for that. And then whenever we moved to the directed payment model, our fee now pays for the upper payment limit, so that 100% Medicare, the managed care gap, so it helps the state with their pull down from that piece. And then it also funds a bit of Medicaid expansion, because the premium taxes that the managed care entities pay, that also goes to help pay for Medicaid expansion. And then there's just another transfer out annually to another revolving fund that the state has. And all this is set statutorily. And so I believe last year our hospitals paid, well, I think it's this year, 2025, $369 million in shop fees to hand to the state and allow them to use to draw down. So, I mean, I would contend certainly, and I understand it's certainly my role, but we have a very successful private-public partnership with the state that has allowed them to utilize these dollars to draw down more. I don't think that most people truly understand how that works.
Okay.
And, we can own that as a hospital association for not explaining that well enough. But we have also had former lawmakers that are no longer there that were also considered, I think, among many experts in this space. And so, for us, it's about a re-education in light of HR 1 about what exactly our fee pays for and what it doesn't.
And I think that is the re-education, just continually telling our story and how we support each other and how we make it work in Oklahoma, I think is important. So I don't think it's a sort of a ding on all of us that we do things, we pass legislation, and what trickles down to the effects. We have to keep telling people why and if it's working or if it's not. And clearly this was working for us.
Mhm.
And so it's nice that you can tell that story in an educational piece that we can all learn.
And I want to be fair, right? I mean, managed care has been in place in the state of Oklahoma in its current format with the directed payment for 1 year.
Mm-hmm.
And so, but that 1 year, as I noted up front, that went from some hospitals being the red and the black overnight. And so it was significant for our hospitals to maintain their operations in their communities. I mean, I point out one particular hospital I know that in the state, and I know that they're not necessarily unique, but their hospital, their cafeteria is open on a Sunday.
Hmm.
And it is the only restaurant that is open on a Sunday because it is that small of a community. And they open their doors, and that's where people go after church.
Mm-hmm.
And so those are the little things that we don't necessarily chat about. I always say our hospitals need to do a better job at telling your story.
Mm-hmm.
That is one of those stories that, our hospitals are community hubs in many places around the state. And for them to recognize and promote that we are Oklahomans taking care of Oklahomans.
I love that.
One of the things that we want to do on the podcast is also kind of like translate this to like policy and how we talk about policy. So, if people are like, well, what should I be advocating for or asking more about in the policy realm? What would you provide to those people?
In the policy realm, well, it's for me, it's less about necessarily policy and more about education and being aware of how the systems work, and however you want to choose to get involved with that.
Mm-hmm.
For myself and my family, obviously I work in the healthcare space. But my son is someone who has been a benefit of Oklahoma's hospitals.
Mm-hmm.
He is someone who underwent open heart surgery. We have, arguably the number one pediatric cardiologist in the nation, if not the world. And, that is amazing that I don't think people, really understand. And so it's, I think it just goes back to storytelling for our hospitals and letting their communities know that, this is what we deliver back to you. And it is not about profit at the end of the day. It is about taking care of all of us at the end of the day because, I've said this before, probably said it to both of you, and I know I've said it plenty of times. Hospitals are often the site of our greatest joy and our greatest pain, and for us to always recognize that, I have always, led my space by what is best for the patients, what is best for the hospital. And I believe our members truly believe that. And, we always open our board meetings in a moment of prayer. I don't know how many other associations do that, but that is very important for us. And so just recognizing that, yes, we have big hospitals, small hospitals, everything in between, but these are all Oklahomans taking care of each other.
I kind of shout out to the hospital in my district, Integris. I had all 3 babies there. And recently I was at an interim study yesterday. It was mine, Health, AI, and Energy, just talking about all the things that we can prove in healthcare with AI. There's so much, that we could so help, not have the stalls that we did because my son needed a surgery. It took 6 months for him to get to the hospital for the surgery, and not because of anything else, but, paperwork, I want to
Yeah.
say, and how long it takes for communication and translation and all of our laws and all the things that we do in insurance. But once we got to Integris, like once we got there, it was one of those things that from the moment we got in the door, our whole family, me, my son, and my other son that was with me, we just felt so taken care of.
Yeah.
From every interaction we had, that they focused on William, and not just the way they do other patients. My son may need a little extra, but I was just truly impressed with the way we were taken care of even after. And so I do know that the care that hospitals in Oklahoma, and I'm not sure that my Integris is the only one that does it, but I do think that it's an important part of our community as well, and how we do have the best successes and some of the saddest times.
Yeah.
So I do think, that the way I hope that it continues to be like that. But we know that change is coming, and then we'll still try to remember that Oklahoma standard and how we do it.
Yeah.
Yeah, definitely. Well, thank you. I think, do you have any other questions for him?
No, I think
But I'm so
Yeah.
happy that you.
question for him.
Oh,
He
that's
gets
right.
to ask us questions.
Well, of course, but I just want to say again how happy I am that you were here. That wasn't so bad, was it?
No, it was fine.
But again, I think that these are things that we have to, explain to people a little bit deeper, because people are making really quick judgments about it.
Mhm.
And I think it's more detailed, and lives are counting on it, and the well-being of our Oklahomans.
I mean, you've highlighted it. I think you've highlighted it as well. I mean, we're all in this together,
Mhm.
Yeah.
regardless of what ends up happening. And so that's the focus.
Great. So, on Between Two Ellens, we ask our guests to ask the Ellens a question.
Yeah.
Do you have a question for us?
I have a great question for you both. Kind of just curious of the origin for.
I was just thinking, if you don't ask that question, we have to say that at the end.
So this is actually self-serving. So do
The
you want to tell the story, or
No.
should we tell the story?
I was just an observer.
observer, well,
I was late to the dinner. I'll just say
yeah.
that.
So
And when I walked in, I'm sorry, I just saw Scott, and I go, oh, I got to sit next to Scott now.
we
At the
had
table.
our Democratic kind of like caucus retreat. And we were in Tulsa, and we had gone out to dinner with the Oklahoma Hospital Association, and Scott sat next to us, or sat next to me.
You.
And then,
I was late, and I sat next to you.
and Scott looks at both of us, and he said, I'm like, you should have a podcast called Between Two Ellens. And here we are. That literally, I mean, in January, I think it was.
A
Here we
year
are.
later.
Yeah. So
Yeah.
thank you so much for your inspiration, for your creativity.
But I think
Still my part.
But I think also, we do have the same names. We're same and different in a lot of things. But I think you pointed out that night, the conversation between us that night was really great and different. We both even had different questions or different ideas, but the whole thing that working together and trying to find better for Oklahoma. So
Yeah.
you were the inspiration. You started it. So we can either blame you or celebrate you.
I guess we'll see on the views.
So was that the real question, or did you?
That
have
was the real question. What I got.
I love it.
Yeah, I love it
I
too.
love it.
So the answer is you. Well, thank you again for being here. And
Thank you for
any
inviting
kind
me.
of updates that you can give us. We do have a website, and we have social media, Instagram, so we can update that as well afterwards. If there's anything changes new when the rural health RHTP comes out and how that affects hospitals, we'd love to hear it.
Awesome. Thank you, Scott.
Thank you
Thank
so
you.
much.